Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
My name is Leah Harris. Welcome to the Mad in America podcast. Today's guest is Paulo del Vecchio. Paulo is a person in long-term recovery from mental health and addictions and has been a leader in the peer recovery movement for 40 years. He recently completed a 30-year career at the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration, where he served in multiple roles, including the director of the Center for Mental Health Services and the founding director of the Office of Recovery. Paulo is now an independent advocate working to advance recovery-oriented policies and practices on national and international levels. Welcome, Paulo. So glad to have you join us today.
Thank you, Leah. It's an honor to be here.
It's an honor to have you. And I'm wondering if you can start off by talking to us about how you got involved in the field of mental health, any of your early activism and lived experiences, movement reflections, or anything you want to share about your entry into this work.
I'll just start with a little bit about my story. And again, stories are the basis of what peer recovery movement is all about. And so my story began as a child. Like many of us, I grew up in a family that knew mental health and addictions intimately. My mom, who I consider the heroine of my life, was someone who stayed hospitalized multiple times during her life. She was someone who was subject to the evidence-based practices of the day, including forced insulin shock treatment. She went on to raise 4 kids by herself, got a graduate degree in philosophy, taught for many years in local community college, nationally published poet, my number one champion. My dad was a Korean War vet, and he didn't talk much about his battlefield experiences, but dealt with it through the bottle. And so some of my earliest memories were the smashing of whiskey bottles and the domestic violence in my household. That early childhood trauma is what I believe led to my own mental health and addiction issues. And as a young person, as a child, experiencing these things at home, blaming myself, became wary, withdrawn, depressed, anxious, fearful, of course. And the teachers at my school in the 3rd grade noticed this, and they decided to ask me to see a school psychologist. And that was my first experience in receiving mental health care. It wasn't necessarily bad talking to that school psychologist. What was bad was she pulled me out of the classroom in front of my peers. And what I remember most about that was the ride home that day in the school bus. What are you, crazy, psycho? What's wrong with you? Going home to my parents and saying there must be something wrong with me. And frankly, that turned me away from seeking care for 20 years. Why would I want to have anything to do with seeking treatment if this was a social exclusion, what we term stigma, associated with these conditions? Instead, I turned, like many young people, to drugs and alcohol to deal with the pain and depression, anxiety I was feeling. So any kind of substance I could get my hands on, getting high morning, noon, and night during school, drinking grain alcohol before school, anything to dull the pain. During that time, also bullied almost on a daily basis from elementary through high school. And compounding trauma is also, one of the things that we know, and has a serious impact on our well-being. And that was certainly the case for me. Like many people, young adulthood was the hardest time. And so there, not being able to get out of bed for days at a time, finding myself feeling that my life wasn't worth living. And I made a plan to end my life 40 years ago, this coming October the 11th. And I found myself on a subway platform. My plan was to end my life in front of a subway train in North Philadelphia, where I was living. And I was down on that subway platform and ready to take that step as the train was coming down into the station, the light approaching. And as I was getting ready to take that step, the thought of my mom pulled me back from that ledge. I say that because family really is important. There are a lot of differences between peers and families, but family support, certainly for me, has been really critical and for many of us. Decided to try to get some help. I went to a local counseling center, told them I was in crisis. They said, come back in 30 days. We have an opening then. How many times do we turn away people, seeking help? But what I found there changed my life, and that was a sign. It was literally a sign on the door of that program for a job. And it was for a job at a local community mental health agency, the Mental Health Association of Southeastern Pennsylvania, where I went to work forming on an information referral line, really what we call a warm line today. And that was my first really introduction to peer support. And um, found three things through that job. One is that I wasn't alone with these conditions. Second thing I found was that recovery was possible and that, in fact, we could overcome these issues. And the third thing I found was that by helping others, we also help ourselves and um, gave me a sense of purpose, a sense of value for my own life. And so that really began my life's work in terms of peer and recovery work from there on.
Thank you so much, Paolo. It's so helpful to hear not only your story, but how you've come to understand your story through the lens of everything that you have learned since, thinking about, right, childhood trauma, compounding trauma, just the power of encountering peer support and how that can shift our entire mindset. So thank you so much for that. Yeah, and I'm curious if you could share a little bit more about some of your earlier experiences with peer support and with that job and with exposure to the movement and how those experiences really shifted your life trajectory.
Yeah, great question, Leah. And I, went back from that warm line job, went back to finish my college degree and got a master's in social work and graduated summa cum laude and went back to work at that mental health uh, agency. And that was in 1987. And came back at that time under my mentor. And I have to give Joe Rogers lots of credit because he really introduced me at that time to the national peer movement. And I had opportunity at that time to meet with some of our really founding members, Judy Chamberlain, Howie the Harp, Sally Zinman, these incredible leaders that we've had in the peer movement. And at that time in Philadelphia, we were going through a process of closing a local state hospital, Philadelphia State Hospital, also known as Byberry, which was notorious for its abuse and neglect for many years. And the state, in their wisdom, decided to close that hospital and develop a range of community services, including peer operated services. So we found ourselves developing a whole range of community peer programming, including drop-in centers and vocational programs. Had opportunity to work with Laura Van Tosh in the Project Oats, which was really one of the first programs nationally to hire peers to do street outreach for folks experiencing homelessness in the city of Philadelphia. We developed housing programs. We also, with the help of Jackie McKinney, another one of my mentors and leaders, consumer case management program that was also kind of on the forefront of the peer workforce that we had today. And in 1987 was also the first time that I attended the Alternatives Conference, and that was a seminal activity for me. And it was, to be in a room with 500 other peers in the sense of homecoming, a sense of acceptance and welcoming like I've never experienced before. That was powerful, and again, that set my life and my purpose to really give me the strength to continue on with this work. And at that time, we were also very much involved in direct action advocacy under Joe's leadership. So I found myself one day chained to the doors of a federal office building in downtown Philadelphia, where we were protesting around homelessness and the need for housing, and spent a day in jail out of that action, and ended up with $6 million in state new funding around housing. Sometimes you need to do those kind of actions, right, to get the change that's necessary. At that time, I also decided to make a change from working outside of the system to try to work within to affect change. And I went to work for the Philadelphia Office of Mental Health, and they're also involved in helping move people long-term institutionalized into communities. And, Leah, some people stick with your whole lives. And one woman had been hospitalized for 50 years. She had fallen in Center City, Philadelphia on a wet trolley track post-World War II Philadelphia, hit her head, probably had a case of traumatic brain injury. Last 5 years, she was in that hospital. She didn't speak a word, and every day the staff would come, they'd lay out her clothes to wear, food that she was going to eat, the TV that she was to watch. She'd been in there about 6 months, and one day the staff came in with her clothes, and she said, "No, I want to wear what I want to wear." And that's really what I believe our work is about, is giving people that choice and voice over their lives, and even simple things about what clothes to wear on a given day, that self-determination. And so that's powered me through the years as well, that experience. About that time was also when SAMHSA was formed in the 1993. SAMHSA used to do an annual conference, the community support program, and there would be a track for peers and families. And one year, because of politics, they decided not to hold that track, and folks weren't happy about that. And so the conference was just a few blocks from where SAMHSA headquarters was, and we're still in that building. They still are in that building. People walked over to SAMHSA's headquarters. That time it was before the tragic bombing in Oklahoma City, where you could walk into any federal building, and they staged a sit-in in the office of Center for Mental Health Services Director Bernie Aarons. Met with him, and then he issued a letter to Sylvia Karras, one of the leaders of that action, where he pledged to hire a person with lived experience to work in recovery. And I ultimately ended up applying for that job and was the first person with lived experience, self-identified person with lived experience working at the agency, because of those people took that action. So the 30 years that I had working at SAMHSA was because of the actions of those people. So we stand on the giants of those that have come before us.
Thank you, Paolo. That's such an important emphasis for this day and age, and especially for people who may not be familiar with this history and what it took, right, to achieve some of these things. So thank you so much for laying that out for us. Moving on to your tenure at SAMHSA, I'm wondering if you can share kind of your perspective and reflections on SAMHSA's accomplishments under your leadership over the past 30 years.
There's a lot I'm really proud of, and I think we have made progress, as in the peer recovery movement. I think SAMHSA's definition of recovery in itself, that we published at the early part of the century, um, continues to hold up over time. The key elements of that definition, that recovery is all about helping people improve really three things. One is their health and behavioral health. The second is to improve their independence, to live a self-defined life. And the third is to pursue their full potential. And I think those key aspects continue again to resonate with communities and states and individuals across the country. So recovery, number one. Second, I would say peer workforce. And here, from that work, that we started 40 years ago to now today, estimates are 100,000 certified peer specialists working in all kinds of settings across the United States. That shows real progress. Obviously, there's a lot of ongoing challenges with that. The need for livable wages for people, the need to have career advancement, the need for people to have recovery-friendly workplaces are all critical and aspects as the peer workforce continues to grow. The third, I would say, is the involvement of people with lived experience overall. And when I was appointed the director of the Center for Mental Health Services, for me and for many of us, that was a landmark event in a way of breaking the Prozac ceiling, I call it. And that really demonstrated, I believe, that peers can do anything. People with lived experience can, in fact, achieve all kinds of jobs and activities if given the opportunity. And I'm proud of my time at the Center for Mental Health Services and the work that we were able to accomplish there. So I found myself in the very seat of where folks staged that sit-in so many years ago, coming full circle. The other things I'm really proud of is work that we did to reduce the use of seclusion and restraint in settings across the country. And they're, developing both guidance and training and regulation and legislation. I had on my last day as SAMHSA, I had another colleague, a young man, come to my office and said, your work really impacted my life. I was in a residential treatment center as an adolescent, and the director came into the program with a piece of paper from SAMHSA, and we ended the use of seclusion on that day. And so having that kind of impact is really meaningful. Obviously, the trauma, again, that the use of seclusion restraint, and it continues to happen far too often in places around the country, in residential treatment centers and hospitals, many other places. Still much more work to be done there. I think then finally, the last 2.5 years as the director of the Office of Recovery, also kind of a capstone to my federal career, at least, doing work to advance peer crisis respites, which has been such an exciting development to see coming up all over the nation, and doing work like last year, technical expert panel on LGBTQI plus and recovery events. So those are a few of the things that I'm really proud of my federal career.
Absolutely. And you did mention, that obviously there's much more to be done on seclusion and restraint. I'm curious if, kind of looking back over your time at SAMHSA, were there any things that you sort of wished that SAMHSA had approached or done differently?
I think the big thing, in my view, is the allocation of resources and really funding for recovery and recovery supports. And again, Congress has a lot to do with that. SAMHSA basically administers the dollars. But, when I started the Office of Recovery, I did an analysis of the funding levels. And, vast majority, probably 90% of the agency's funding, probably 95% goes to treatment and service delivery. About 5%, 6% goes to prevention activities. And really recovery supports are less than 1% of the funding that really gets forward. And, if we talk about rebalancing care in the country and moving towards home and community-based services, and what are ways to keep people living healthy in communities, then recovery supports things we talk about, health, home, purpose, and community. Having access to quality and affordable health care, having a safe, affordable housing, that's probably number one. And the data is really clear on this. We give people housing, a safe place to lay your head down at night. That's probably the most important thing for people to be able to recover in long term. Third thing, health, home, purpose, having jobs, having education. We know those are critical. And finally, health, home, purpose, community, having peer support and family. These are the things that sustain us in terms of our recovery. And yet, less than 1% of funding goes to these things. So We really need to invest much more in terms of long-term recovery supports, like health, home, purpose, and community.
Thank you for those reflections, Paolo. Yeah, it really does seem that, in particular, housing, right, is this drumbeat that so many of us have been on for so many decades and so many years, and it is this fight that obviously continues today. But thank you for kind of laying out, some of those areas of reallocation that really need to occur, right, to achieve those goals that you talked about. Okay, so moving on to kind of thinking forward, what are your thoughts on SAMHSA's future direction? Where do you see things headed at the agency?
A lot of concerns, and my my retirement event, I talked about what I term the three C's, and that's the carceral corporate complacent state. And first, in terms of carceral, the ongoing criminalization and increased use of involuntary interventions and coercion that we're seeing across the country. And again, this is bipartisan, right? We're seeing this in red and blue states in particular, in fact, the increased use of outpatient and inpatient commitment. When we see our president calling for increased institutionalization and long-term institutionalization, if that's making America great again, that's a real problem. I mean, we cannot turn back to previous times of backwards that this nation experienced, and those of us with these conditions, and the loss of hope that that brings to people, the loss of meaningful lives for individuals. So that worries me, hugely. And, uh, in the coming years, we're going to see increased push for more federal financing of long-term institutional care through lifting of the institutions from mental disease Medicaid financing. And that's right on the rise and coming quick. And so, that's very worrisome. All the focus we've had, both at SAMHSA and across the nation, on crisis care. And yeah, there needs to be crisis supports, but, not hospitals. That is not the answer to what we need to have happen, which is, first of all, preventing crises from occurring in the first place, and then alternatives to hospitals and emergency rooms. Things like crisis respites, in fact, are really key. So, concerns about the carceral state. The second is corporate. And what we're seeing here is, mental health in history has been community mental health providers and the like. And what we're seeing now are private equity firms hiring up community behavioral health providers across the nation, where quality of care is not necessarily number one, but the profit margin is. And so, what this means in terms of the corporatization of care and the quality of care and the potential for abuse and neglect, we know, for instance, private psych hospitals have a sordid history when it comes to quality care and abuse and neglect issues, and frankly, fraud as well in terms of Medicaid fraud. And so, again, the combination of the privatization of care along with the carceral, you can see a really a concerning kind of match there in terms of the push for more increased hospital care and involuntary hospital care, along with private interests that perhaps are pushing this as well for their own profit margins. So, corporatization and the need to adjust private equity firms, are a major concern. So, carceral, corporate, and finally, the third C is complacent. And the worry here is, with things like the peer workforce, has the peer recovery movement become more complacent? Are we satisfied with the, jobs, these low-paying jobs, in fact, that many of us are receiving? And the need really to speak out, the need to have advocacy, not just peers, but frankly, well-meaning providers and policymakers and others, um, particularly during these times where our very rights are being threatened. All these things are major concerns. I'll add, in addition to these three C's, the concerns about the attacks on diversity, equity, and inclusion and accessibility. I talked earlier about the LGBTQI plus work that we did in the Office of Recovery, and the guidance that we developed out of those expert panels were removed from SAMHSA's websites. That's just one example. Across government, of course, all efforts focused on diversity and equity and inclusion are being removed. And, that's, again, not about making America great again, but putting us back decades and decades. And so, when we look at SAMHSA's future, we also have to question what SAMHSA, if SAMHSA itself will even have a future when we've seen major layoffs and firings occur, across government. So just before I left SAMHSA, in fact, half of my staff at the Office of Recovery were terminated. And most of these were individuals that were hired through Schedule A disability hiring authorities and had a longer probationary period as a result of that and were terminated without cause. And this included veterans as well on my team that were terminated this way. We also have to, with the push from across the Trump administration to look at shrinking government, will SAMHSA be combined with, another agency? There's been lots of rumors about that in the past, and you certainly, not having a federal focus on mental health and substance use. And folks can criticize SAMHSA, but the agency has been, I should say now, a central point around advancing peer voice and recovery concepts and, not having that central federal voice anymore will be also a way to push us back decades. So those are a few of my concerns about the future of SAMHSA and the direction of mental health and addictions overall.
Thank you so much, Paolo. It's really helpful to kind of think through that framework of the three C's as well as the equity and access pieces to really understand the sort of intersecting nature of this beast, right, that we are collectively confronting at this time. So thank you for that analysis. So I'd also be interested in hearing a little bit more of your thoughts on the current state of mental health. You've already touched on the rise of outpatient commitment, right? But also there is the increasing diagnosis of children and young people, among many other issues. So in your opinion, where do you really see the United States as a whole heading in terms of these kinds of challenges?
And we talked earlier about homelessness, and that's a huge challenge when we have record numbers of people living in our streets and shelters. Last count from HUD, 770,000 individuals on any given day. And as we spoke to before, there's an affordable housing crisis in every community across the nation, and yet people who are unhoused are too often blamed for these conditions and then subject to things like being swept off the streets, subject to involuntary treatment. And the proposals for things like wellness farms from the current administration are like really concerning about, forced labor in these settings and things like, are these going to be voluntary and that nature? So homelessness, I'm very concerned about. I do think there's some things that we've learned over the years. First, we talked about my own personal experience about trauma, and we've certainly seen a lot of progress in trauma-informed care. But, a lot of it is in words only. So, how can we really assure that we look at how trauma impacts the development of our conditions? How do we look at preventing trauma in the first place when we think about child abuse and sexual abuse in particular, so prevalent in our communities, often untalked about? I think if we really want to look at preventing mental illness and addictions, we need to get in front of these issues. So those prevention issues are critical. Related to that is I've really come to believe that inflammation is in fact at the heart of many of the conditions that we experience. Inflammation is often triggered because of traumatic stress. And so you can connect the dots here that, the traumatic stress impacting inflammation as bodily functions that is clearly connected now. And then science is really clear, the connection from inflammation and things like our gut microbiome, in fact, impacting the development of mental health and addictions, including psychosis as well. And so, more ways we can look at inflammation. I also think we're seeing a greater recognition of the limitations of psychiatric medications and, efficacy of medications, and this audience knows well, are, limited, 30% efficacy, across on average. The development of things like psychedelics hold lots of promise, one course of treatment. Again, the corporatization of psychedelics is also a concern, but, the growing recognition that needs to be much more of whole health, holistic care for people really to achieve wellness in long term. When it comes to children, we're seeing rates, particularly among youth and girls, of high rates of reported depression, anxiety, suicide, still second leading cause of death among our nation's youth. And, it's not too surprising with the anxiety, the trauma that youth experience growing up in this world today, from everything from climate change to the politics that we're experiencing, to gun violence, and the, experience in our schools. It's not a surprise that our youth are in crisis. And so, again, I think we need to look at trauma in what our youth are experiencing ultimately to help solve these issues rather than reverting to things like more medications or residential treatment centers, for sure.
So, thinking about some of these challenges that you have laid out, what are some of your views on the current state and opportunities for the peer support and recovery movement?
Well, again, we talked about the peer workforce earlier, and my hope, and I think many of our hope, was that the peer workforce would be the Trojan horse to get within mental health systems and really affect change from within and promote recovery and trauma informed care and rights protections in particular. We do not, and the fear has always been, right? We don't want to create an oppressive mental health system simply with using people with lived experience as the workforce. And so, it's really incumbent on us to look at ways of avoiding, peer drift, as we've called it, right? To keep the values and principles of what the peer movement has been about self-determination, about choice and voice, about rights protections, front and center as the peer workforce continues to grow. I think continued opportunities there. I think there's also opportunities to frankly take a bigger tent approach with our work. And the work of the Office of Recovery, we were very much working towards that. So not just mental health, but bringing people in recovery from addictions and substance use, working as colleagues with mental health peers, because really they're all one similar issues that we're facing. I also think opportunities working with the broader disability communities also holds a lot of promise around community living, around self-direction, determination, independence. And I also think, and again, I shared earlier about there's been differences between peers and families, but joining with families around things that are common ground. Things like peer support, in fact, things like home and community-based services. These are all things that families and peers can agree on. So ways of working alongside, supportive families, I think also present a lot of opportunities. I think there's opportunities again with crisis care, with the focus on that. We talked about peer respites, and we're seeing incredible growth in peer respites, which were really Judy Chamberlain's vision in On Our Own in her seminal work. Right there, seeing that come to life, it's been awesome. I also think again, getting back to the roots, mutual support. We're going to face a lot of tough times in the years here ahead in getting back to people at local community level supporting one another through mutual support groups. We don't need government to convene a support group. And so getting back to the roots on that. And the final thing, I talked about complacency earlier. And, one thing I certainly have learned in my career in government and the history tells us is that progress only occurs when people make demands, to paraphrase Frederick Douglass, in that, we need to speak out. We need to be vigilant. We need to continue to advocate around rights protections because particularly during these times, and it might be some risks involved, but the long-term benefits of speaking out, of using our voices, not only for ourselves, but for our peers, will make all the difference in the long run.
Paolo, appreciate that really galvanizing and inspiring way of seeing the work ahead of us, and the reminder that we can all draw on the lessons, the learnings, the actions of the early movement, and really allow that to move us forward with that ancestral connection to our movement and its foundation. So thank you for that. And I just have one last question for you. And this is really in terms of what is next for you personally, right? After this 30-year career at SAMHSA, what are you excited about being involved in next?
Well, I, may have retired from federal service, but this has been my life work, and I'm, going to continue. There's a saying in the disability community about I'm not dead yet. And so, I'm going to continue to be active and involved. I'm going to continue to use my voice, after 30 years of being a federal leader, that, and I do it through LinkedIn and through other things as well, ways to get the word out. I believe that someone taught me early in my life, my dear friend and colleague, Roberto Romero, that the adage of each one teach one. And the more that we can continue to share knowledge and use our voices, that will help ultimately to empower us, empower new voices in the next generation to come up to continue to speak out and speak truth to power.
Well, I think that is a perfect note to end on. I want to thank you so much once again, Paulo del Vecchio, for joining us today on the podcast.
Thank you, Leah.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.